Hi, I'm Kelly Beasy, a nurse practitioner, clinic owner, and aesthetic medicine educator with HealthCert Education. Welcome to the Aesthetic Shift, a HealthCert Education podcast series for cosmetic practitioners like yourself who are looking to evolve, diversify, and future-proof their aesthetic practice. In each episode, we're going to explore core cosmetic topics, like treatments, complications, ethical marketing, along with complementary areas that you may wish to bring into your practice, such as women's health, skin rejuvenation, gut health, weight management, and more, to help broaden your offerings and build a more resilient practice. So we're going to dive into today's topic. Today we're talking women's health with the Dr. Amanda Sabel. Welcome.
Hi.
So Amanda's joining us all the way from Bunbury, where she has her clinic called Health by Nurture. Now, Amanda has established a flourishing practice there, bringing menopause front and centre. Her journey is quite rich and multidimensional, coming from London, where she trained, completing a surgical rotations, burns and plastics, and working in emergency medicine. So quite interesting areas. So during her GP practice, Amanda earned diplomas in women's health, ear, nose and throat surgery, very different areas to learn in. In London, she embraced the portfolio of GP roles encompassing women's health with urgent care. Later, she moved to rural South Africa before relocating to Western Australia in 2017, where she's built a flourishing practice there. So Amanda, we'd love to hear about why did you settle back in Australia and what brought you to women's health?
Okay, well, I came to Australia because we were living in the bush in South Africa, and my son, we discovered, needed to go to school because we were rubbish at homeschooling. So that was the impetus to move here. Women's health is something that I fell into, really. I came from, very surgical focused background, very alpha kind of stuff. And it was really just in my GP training doing of gynae during that I realised that it's actually a really lovely specialty. And I wonder if I hadn't been quite so old when I finally went into my GP training, if I might have chosen that as a career proper. I really enjoyed obstetrics, and so the reason I ended up in Western Australia was it was the only job at the time that was GP obstetrics. And so I really, really enjoyed delivering babies and had my babies quite late in life. And the move into menopause itself really was from my own journey and just feeling really dark to get help. So am I allowed to be a bit of an oversharer?
Absolutely. I think we hear this a lot, is that women reach a certain age where they start experiencing the perimenopause, and that's the impetus to explore it further and offer it clinically.
Yeah, so I was, had a baby, a breastfeeding monster. I was 40. I was in actually a more rural area than here. It was really hard to get her off the boob. And so to do that, I went on the pill because that was what was in the cupboard at work, just to try and down my milk supply and put her off. And then I started having hot flushes randomly. And having been in South Africa, rurally there, and done a lot of TB and HIV work, and not necessarily always worn my N95 because being pregnant in the 40-degree heat with an N95 on is hard.
Yeah.
I assumed I had tuberous spine, obviously,
big
which
jump.
is really out there, but it seemed like the most obvious things. I had back pain, I had night sweats, like that's the environment I'd come from.
I guess menopause wasn't on your mind at that point.
No, I had no thought of it. I had a baby at 40. Both my grandmas had babies in their mid to late 40s. So I had no anticipation that I would hit perimenopausal symptoms at 40 with a little baby. And so, eventually one night my husband went to me, darling, I think it might be a change. And I was like,
Did you punch him?
Yeah, pretty much nearly. And then I kind of couldn't possibly get a marina put in by my colleagues at work. And I actually very naughtily self-prescribed some Epidoc and felt so much better. And then I was like, this is actually not cricket in the world of medicine. This is a bit frowned upon, self-prescribing. So I went to see a posh gynae up in Perth who was like, no, you can't be. You're too young, rubbish. You can't have it. And I was like, but I want it. It makes me feel so much better. And so he made me come off my patches, go on paroxetine, which is gross, and then do bloods like every 48 hours. And the minute that FSH was over 10, I was like, I'm in, man. Stop. I can't do this anymore. And I just felt as if I'm a doctor, I've got a diploma in women's health, I've got GP fellowship, I've got a pretty, strong stand up for myself kind of personality. How on earth do other women feel who don't have that voice and don't have the ability to back themselves up? So that's where the menopause part came in for me.
Yeah, absolutely. And while it's a little bit of a different story, it's a familiar story that we're probably hearing a lot. Can I ask how long ago this was? How many years?
Well, 10, because I am 50.
Well, you look
Um,
fantastic. But so I think we've come a long way in the last 10 years, but we're still hearing stories like this where women are being told that it can't possibly be menopause. So if you're a doctor or a nurse practitioner or someone who's wanting to bring in women's health, what would you say the big barriers for them to bring women's health into their practice? And then secondly, to get their education and training, where do you start?
so I think within a lot of primary care, there's a real time pressure. Menopause is so complex, right? There are estrogen receptors in every single cell type, and we already know that. And there are probably progesterone and testosterone receptors in every single cell type as well. We just haven't worked it out yet.
Yeah.
And so it's such a huge topic. It can't be done in a 10 to 15-minute appointment. So that's the number one. Number two is a lack of training within GP curriculums in medicine, and I'm sure within the practitioner training.
Yeah.
There's nothing. Like, there was one lecture in undergrad on menopause back in the day, and I'm so old, I'm pre the Women's Health Initiative study. But it was one lecture, and it was like, oh, if you've got bad vasomotor symptoms, you can go on Premarin. That was it. And then there's the fear from the WHI study that people still are a bit scared. And that's something that we really have to work hard to change that. Because I think women, particularly millennials, are so much more educated than a lot of us as GPs, that they're coming in with information and then they're getting beaten back. And, when you look at the community like Facebook groups, etc., it's a very negative culture towards healthcare professionals, which is really sad.
Yeah, it's a real shame, isn't it? Like, do you think that medical training nowadays has possibly changed to encompass a little bit more women's health, or do you know if
So
there's any
that's an
change?
interesting question. I have medical students here once a week that do their women's health part of primary care with us. There are 3 medical schools in WA, and I think the curriculum between the 3 is actually quite different. One is actually much more modern, up to date in menopause care, but still some of them are coming from the other 2, and they're still WHI stuck in their head focused, which is really sad. So hopefully in time, which won't be too long, we will have a generation of junior doctors coming through that know the things already.
Yeah. Hopefully it's changing. And I mean, I think that there's definitely a big shift out there amongst some of the well-known, particularly American and British doctors, to sort of publicize women's health. And like you said, women are a little bit more proactive in their seeking out these treatments. So you mentioned before that primary health care, you're very limited in terms of time. So how did you then go on and decide? Obviously, a menopause consult or a women's health consult takes maybe an hour or so. So what would be the big barriers for you to bring that in? You obviously have a thriving practice. How did you then go and set aside all of that time?
So I think a lot of within, I know that nurse practitioners only have 4 codes, but within DEM, which is a different problem, but within primary care, I think making it affordable for women is a big thing, and a perceived barrier. And formerly I don't know, we're allowed to talk about money. Formerly I was a, mixed billing. Now I'm completely private billing, but I do try and use codes effectively to help reduce costs for women. So, we've got the menopause, perimenopause health assessment code of 695, but you are allowed to co-bill that with mental health until the 1st of November. So with 2713 or 2712, you can also co-bill with time. I think that's really important to make good use of the codes available to us within Medicare to make it actually a little bit better from a cost perspective to patients. And I think women want the time, right? So it's something that they're actually prepared to pay for and prepared to invest in if they feel like they're going to be heard and they're going to get an outcome that makes them feel better.
Yeah, that's a great point. Like time, and I think also building that relationship with the woman potentially prior to delving into the intimate details of their woman's health and genitourinary symptoms and even sex life and libido. It's often not something that you would do the first time you meet someone potentially.
No, I think, yeah, I'd like to think that I, generally speaking, quite able to develop a pretty decent rapport with people quite quickly. And I think because there's quite a wait for people to get patients to get an appointment with me, they're generally quite prepared. And I would say there's probably about a 50-50 split on women that are prepared to talk about that from the get-go. And then other women that they do need a couple of visits to warm up to be able to bring up those things.
Yeah. So on that, like, how would you go about setting the tone to make women feel comfortable to discuss those sensitive topics, like particularly mood and sexual health? I mean, that's a little bit hard for people to open up to. So how would you set the tone for that? Any tips?
Well, I think, having a nice environment, using all your non-verbal cues. So I think, having open body language, using non-verbal cues, having a nice room, trying to make sure that you've got a decent amount of time for it. And how I often start when they've got a whole list of symptoms is I give out the modified green score questionnaire and get them to fill it in, because that's quite a non-confrontational way of asking those questions without them having to verbalize things.
Yeah, that's a really good tip. So get them to pre-fill the questionnaire prior to the appointment, and then you can run through with them. And then when you see the woman, would you like to give us a little bit of a rundown on sort of what are the things that you look at during the consult and possibly some of the investigations that you might do if you do them?
Oh gosh, so I think I try and run through all the symptoms, and a lot of my patients' focus isn't so much on hot flushes. It's primarily mood, weight, relationship, libido, energy, the feeling like they can't do their job anymore because their brain, something happened to their brain, the brain doesn't work effectively anymore. I find that trying to work through all of those, it's a lot, right? And then, making sure you've got into the bone density and diet and lifestyle. But, when you look at what the evidence is, actually the evidence for HRT is greatest in women from lower socioeconomic groups, because they don't have the time, ability, resources to do all the lifestyle things that help their health. So actually HRT on its own is the bomb. And that's something that I think we need to really try and promote within the medical community, that we're not giving women back their hormones is actually a good thing. And, we need a bit of a mindset shift that yes, it's natural, it's normal. It's like every other disease process, and we treat that. This is a primary endocrine organ failure. And hopefully within time, this mindset will change, that more people recognize menopause as such and just treat it without making women feel bad or that they should just turn stupid and give up work.
And I think if people understand that while it is a natural occurring thing, women feel terrible during this time, and there's a solution that can make us feel better, more productive, less likely to leave work, relationships, and all of that. Why wouldn't we utilize the resources to make people feel better?
Exactly. So yeah, I think establishing a really good rapport, setting the tone, and I kind of try and be a little bit lighthearted or funny about it, or reflect on my own kind of cuckoo episodes, or feeling terrible, or like trying to sort of engage with someone to make them feel like they're not alone and that they're not being weird, and that this is really common and you see it all the time. And I think that works well.
Yeah, creating empathy, giving empathy and things like that is really great. So in terms of investigations, do you do any, and what would you do?
Oh, look, it depends on the age of the woman, right? So, I mean, I'm very liberal with my hormone prescribing, but even so, if you are under 40, I will do the blood because the FSH, the hormonal blood, because I would look like a bad person if I didn't. Even if they come back as normal, there is no harm in giving them a 3-month trial hormones to see how they feel. Because as I'm sure you know, and I know, diagnosing perimenopause on blood is a rule in, not a rule out. Same as diagnosing diabetes on a random blood sugar, it's a rule in, not a rule out, right? And we need to get that message across. So I tend to do all the other things. So I like to just do, all the other things to rule out other underlying medical causes of making women feel terrible. So for blood count, using E's, LFTs, lipids, HbA1c, fasting sugar, thyroid function, vitamin D, they're kind of like my baseline. Vitamin D deficiency is super common. Iron deficiency is pretty common. Non-alcoholic fatty liver disease, pretty common. And, dyslipidemia, pretty common in perimenopause. And what I like to do that, and then I like to do it after a few months on hormones to show the improvement, to show that estradiol does help your cholesterol, estradiol does help your non-alcoholic fatty liver, estradiol does help your sugar control. So, I think that's right. That's a really good positive way for patients to see objectively that their health is better on hormones than without hormones.
Yeah. And that's another argument for hormones, right? If we're seeing an improvement in all of these other health factors, then it's clearly good for us. So, it's a great one. I just want to circle back. You mentioned DEXA scans before. So obviously in Australia, the DEXA scans, they're only Medicare subsidized from age 70. Is that correct?
So you can get it on, there are other things. So any kind of risk factors for osteoporosis, you can get them. There are 2 different Medicare rebatable codes. So lots of chronic diseases like thyroid disease, any inflammatory arthritis, and then, extremely low BMI, low mechanism of small fracture, low age of peri. They're all things that you can get a rebate. But to be honest with you, I think when women are coming and they are invested in their health, they actually want to invest in the sector. And as in the grand cost of things within healthcare in Australia, it's not that bad. It's a couple of $100.
So would you do a DEXA scan as a routine or by request?
I always offer it. Always offer it.
Yeah. No matter the age of the woman.
No, if they come to peri, then I would offer it.
Yeah. And then would you say repeat that in a year, 2 years?
So 2 years normally. So if they're and then once they've had the baseline, if they are osteopenic or osteoporotic, they get Medicare rebates on all the following future scans. So sometimes it's worth the investment in the first one to get the ongoing scan covered.
Yeah, I think it's a great idea. Okay, so just looking at lifestyle interventions, do you have any particular lifestyle interventions that you recommend alongside your HRT?
Oh, of course. Because as much as I love the hormones, it's not the whole story. Yes. So yes, absolutely, getting people off cigarettes, getting them down. A lot of women tend to start self-medicating with food at the end of the day to try and get that alcohol consumption down. Upping exercise. Sometimes though with exercise and weights, really they only really start to get the motivation to get out of bed. We don't do that once they get on testosterone. That's a whole another huge topic all by itself. But the lifting heavy weights, I do tend to make use of GP management plan. That's not called GP management plan team care arrangement anymore, but whether it's called chronic disease conditions management plan. So to try and get women in with a dietitian and an exercise physiologist, so that they get extra time with a different voice that's not me telling them the same thing, to reinforce the message and get them their headspace into the right point that actually, I actually do need to lift these weights and actually do need to eat better.
Yeah, true. So just quickly, you touched on testosterone. Obviously, we hear a lot about testosterone. There's a bit of a stigma about not prescribing testosterone, but briefly, I know it's a big topic, but what's your thoughts on testosterone? When should we prescribe testosterone? Why not? Why should we? What's your thoughts?
So I tend to get women sorted on estradiol and their progestogen of choice first. And then once that's stable and optimized, then look at the testosterone. Personally, I know that there's a menopause doctor sort of fairly local to me who gives everyone everything on the first appointment, and I think that's a bit overwhelming for them. They don't know where to go with it. So what I like to do is sort estradiol and progesterone out first, and then look at the optimum absorption of the estradiol, and then look at that androgens, and then add in testosterone. So most women do need testosterone, but there are lots of women who actually have got really high androgen levels and they don't need it.
Okay. All righty. So what would you say the risks are of not addressing menopause symptoms in a clinical setting? So if women come in with a whole bunch of symptoms that fit the classic menopause symptomology, but they're not treated for it, what would be the risk to that woman in terms of their clinical health?
Well, this is obvious, right? So you're increasing their blood pressure, you're increasing their insulin resistance, you're increasing their fatty liver, you're increasing their BMI, you're decreasing their bone density, you're giving them more sort of metabolically inactive cells, which is sending out more inflammatory signaling to develop more cancers. You're ruining their sleep, and you're making them sad or grumpy or both.
A whole lot of clinical things going on there, isn't there? Not to mention relationship potential breakdown, workplace, depression, worsens anxiety, all of the things. So I guess there's no reason why we shouldn't be addressing menopause in our clinical practice. So why do you think that there's a hesitancy around prescribing of these medications or treating these women? And, we keep hearing women being told, you're not in menopause, their bloods don't reflect it.
It's complex, isn't it? So there's a bit of a societal thing. Women against women, like I suffered, like your mother's generation, I suffered, you should suffer. Right? So there's that part of it. Then there's very young practitioners that haven't been through it, that have been told, oh, it's just natural and it's a phase, and haven't experienced it yet themselves. And they're like, what are you moaning about? There's nothing wrong. Shut up, go away. And then there's the older practitioner who sort of becoming sort of up to retirement age now, who are like, oh, I suffered, you should suffer.
Yeah. Mentality,
boys are often quite scared of lady stuff.
Yeah.
Definitely throughout my medical career, at medical school, the boys didn't want to do the O&G rotation. They didn't want to go into first week. In ED, the boys never picked up any kind of TB bleeding or winning stuff from the box to see patients. In general practice, they're like, oh, I'm not sure about that, go see a lady,
Yeah.
So I think and even within my practice, my boys, I've got 3 male GPs with me who are all really, really, really lovely. But, they can be really nervous about examining women. They're quite scared, actually, that something's gonna go wrong, or they're gonna get a complaint about them. So it makes them very reluctant to examine women, which is a bit sad, really, because yes, there are some hideous practitioners out there that really abuse their privilege as a physician. But 95% of
they're few and far between.
Yeah.
Okay, so what would you say top 2 practical tips for running a smooth and effective menopause consult?
Practical tips. Well, number 1, listen to your patient. So, I don't know, like, go back to your communication skills class at med school and do your active listening. So, like, let the patient talk. So when they come in and sit down, it's an open question, how can I help you today? And just see what they say, and just let them talk until they finish talking, because it will save you time.
Yeah. Do you use an AI assistant?
Right. Yeah, I do. We use Live in the practice because it integrates into Beasy. And I have got a menopause health assessment template that I've set up myself for it. So that definitely helps with timekeeping. I love an AI. So we also use another app that integrates with best practice called Better Consult. So I don't know if you know that one, that sends out a text message to the patients before their appointment so they can fill in what they're coming for.
Oh yes, I've seen that. Yeah.
And it's a bit of a triaging, and so you can see a bit in advance what they
Yeah.
want to talk about. But again, not everyone fills it in. And then some people are just embarrassed about what they're coming for, so they just
True.
say check up. People like,
Yeah.
oh,
True.
yeah.
Personally, I use Heidi Health, and I do find that that has really changed my consults. It's allowed me to do a lot more of that active listening because I know I'm not going to forget anything. So I can fully concentrate on that person in front of me without, typing and writing. And, often hear the feedback from patients where the practitioner doesn't even look at them because they're just typing on the computer. So that's something that doesn't really make people feel empowered to share what's really going on. So that's a really good tip, the active listening. Do you have another tip about the menopause consult or bringing it into practice? How to maybe bring it into your practice that you already have?
So, are we talking about in aesthetics or in GP?
GP, I guess. Maybe
Yeah.
aesthetic and GP.
So within GP, I think my doctors that work with me are like, you think hormones can cure everything, and I'm like, well, they probably pretty much can. So for me, it's quite natural to bring in almost any complaint back to how their hormones are doing.
Okay, yeah.
So when women, there's papers going back 10, 15 years showing that if any woman kind of over 35 comes in with a new onset mood disorder, that you should probably give her estrogen rather than putting on an antidepressant. So if we were to, rethink particularly mental health and new onset anxiety and depression in sort of, that older reproductive years woman, we could change, revolutionise and massively de-escalate the number of people in Australia who are on SSRIs that probably didn't get the need them.
Agreed. Yeah. So I guess just to wrap up, a couple of final questions. What would you say the weirdest or the most surprising menopause symptom you've come across would be?
So itchy ear canals, I reckon.
I've had that. I've had that. Odd.
So this woman had really itchy ear canals and she put some estradiol in there and it got better. It's like,
Oh,
oh no.
okay.
Not recommended, but it worked. So good on you.
So her vaginal estrogen, she popped it in her ears.
No, the estradiol.
Oh, the estrogel. Oh, okay.
Yeah.
Interesting. Yeah, it's an odd symptom. I mean, we're seeing now 70 plus symptoms of perimenopause. It seems like everything that goes wrong with us in that age bracket is potentially peri or menopause. Now, finally, if there's any one myth that you would like to bust about menopause for either clinicians or patients, what would it be?
Well, there's two. One, it doesn't cause breast cancer.
Yes.
It's neutral, right? And number two, actually, it protects your heart. So please don't think that you should stop it if you've got high blood pressure or high cholesterol or cardiovascular risk factors that are increasing, because it helps keeping them down.
Yeah. Great. I actually have one more question. I'm sorry.
Sure.
I know that you run your women's health along with your GP, along with your aesthetic medicine together, and you love lasers. So I'd like to know what you're using lasers for in your women's health.
So I've got an aesthetic practice that's separate to Health by Nurture called New You Aesthetics. So we do a laser there. So
Yeah.
I do quite a range of treat quite a range of vulval skin conditions with laser alongside traditional application creams, etc. So, I have really amazing results from lichen sclerosis, which like to treat to get rid of or reopen up fused labia. That's really helpful. I use it in lichen planus. I use it in Zoom sarvitis, as well as all of the other kind of genitourinary syndrome of menopause. I use it for atopic vaginitis, stress urinary incontinence, mild to moderate prolapse. So particularly cystophiles, I think it works better on cystophiles than rectophiles. Rectophiles are really tricky to manage. And then just general vaginal, cosmetic vaginal stuff. So like labial, making labia majora, tighten them up a bit again, and making the labium a bit less, a bit smaller.
Okay. Yeah. So that's a really interesting use of the lasers, and obviously with your lichen sclerosis and lichen planus, that treatment would be life-changing for women because it's an awful condition.
Absolutely. Like I've got this beautiful, beautiful, beautiful elderly lady, and she's been operated on, twice,
Mm,
where the lichen had fused everything together, and she just had like this tiny, tiny little opening for her urine to come out, and it wasn't even, it was ballooning and not coming out properly, and she was getting UTIs because it wasn't, the pocket wasn't emptying properly. So she's had two ops to open it up, and it had refused. And so I lasered her, with using, it wasn't, not fun, deep sort of fractional laser. And we're 2 years down the line now, and you can see her urethra still. It's amazing.
wow, that's amazing. So I know we've talked about this before, but you would be one of the few people in the country that's using the lasers like this. Do you know of many people around the country for the clinicians that are listening, they might want to access this service?
So it's really, really tricky these days to get insurance. In my mind, it's actually quite a political thing. RANDCOG sponsored a study that showed that there was no benefit from the laser, but it was a retrospective reporting. It was a self-reporting study. There was no objective measurement of tissue, and the time intervals weren't great. However, if you look at studies, there's been a multi-center randomized double-blind controlled trial in the UK using the laser that I have versus placebo, and it showed a massive improvement in stress urinary incontinence in women. It is tricky to get insurance. I think I am lucky because I was previously insured before this study and had a bit of a bun fight with MDA to keep my insurance, but I still have it.
Excellent. So there's some other clinicians in Australia doing it that you know of?
Yeah, there are. I think there's definitely some overseas in Victoria. I think there's a GPO in Perth that does morphia. So there are a few of us dotted around the place. It's difficult because you can't really advertise it. So it is very much a word of mouth referral basis. And to be honest, I'm actually pretty busy with doing vaginal laser because women talk to each other.
Absolutely.
And,
Yeah,
clearly, if you don't advertise something and you're busy doing it, it must work.
absolutely. Okay, well, that's really, really interesting. So, where would you recommend people go to get further education and information around menopause and women's health?
Well, this is tricky, isn't it? Because I hadn't realised how incredibly political menopause care was until I went. Did you go to the World Congress in Melbourne?
I didn't.
Story. There was like nearly stand-up fights in some of the rooms. It was crazy. However, you can look at the Australian Menopause Society website, the BMS useful training. The NICE guidelines from the UK are pretty interesting, but they're incredibly biased, which is a very political thing. Jean Hales is really good. And then looking at the kind of doctor menopause community online. So I really love Kelly Casperson. She's an American urologist. She's really all about the genital urinary syndrome and menopause, but just hormones in general. Vonda Wright's amazing.
Yeah.
She's an orthopedic surgeon. She's really into the musculoskeletal syndrome of menopause. And then Sarah Whaler, who is she's somewhere from one of the South American countries. I can't remember which one, but she's based in New York. She's an endocrinologist, and she's really into HRT and the GLP-1s, which, I think as a doctor, I don't think you will have a more satisfied patient than the woman that you put on hormone and a GLP, and she feels better and loses weight. She will love you forever.
I just saw something that said women who take a GLP-1 with their hormone get much better results. I can't remember the percentages.
Yeah, 30% greater weight loss. Yeah.
Yeah. All right. And then obviously HealthCert do offer women's health courses as well.
Of course, yeah.
Thank you, Amanda. We really appreciated your time this morning. It was very interesting. Thanks for joining us.
No problem.
Thanks. Okay, so that's it from me today. Hopefully you found this episode helpful. So if you're looking to start or deepen your skills in aesthetic medicine, I highly recommend exploring the HealthCert University Assured Aesthetic Medicine Pathway and their other courses. They have certificate courses with CPD accredited. They're designed for real world practice with practical one-day workshop held in Melbourne, Sydney, Brisbane and in Perth, they have live demonstrations as well as hands-on injecting. And if you're interested in taking things further, we can arrange for one-on-one personalised mentoring. That's here in Brisbane with me or around Australia. So thanks for tuning in, and we'll see you next time on the Aesthetic Shift.